Hi everyone. Good evening. A very good evening to everyone. Good evening, everyone. I hope I'm audible and visible. Dr. Neha, you also can unmute yourself. And hi, Neha.
Hi, good evening.
Good evening. Good evening. So I think we can start. We have the enough, reminder and people here and on YouTube. YouTube also there are uh,
Yes.
many people. Yes. Thank you very much. Someone is writing in YouTube. Sir, is it true we get participation certificate for webinar? Are there any rules such as filling a feedback form to get like last time? Yes, there is a rule. If you are not filling the attendance form, you are not going to get the certificate. That's true. Because how would I know, or how would we know, or how would my team know that you are present in the class? Okay, so
Yes.
it is mandatory to all of you. To be here with us till the end. So that time we share our, the attendance form, and that time you fill it. So it is attendance form come feedback form. We share that, and you have to fill that. Otherwise, that will be a trouble for all of us to, because there are almost 3,000 registrations for today's webinar. Almost 3,000 registrations. It is very tough to ensure that who is, coming and joining the webinar, who is not joining the webinar. It is very tough for us to manage those things, right? So you all have to be here. That will come to that later, that part, the eligibility part will come later. Okay. So let me welcome you all again. Good evening, guys. I'm Dr. Ajit Singh, founder and CEO of the CliMed Research Solutions. And today I'm welcoming you all for this wonderful free webinar on core principles of antibiotic stewardship, right? Where Dr. Neha, our today's resource person, will be talking about optimal antibiotic use, de-escalation strategies, and duration of the therapies, and multiple things, right? So before I come to other things, let me introduce Dr. Neha. So Dr. Neha is basically the PharmD, Doctor of Pharmacy, and she is the distinguished healthcare professional with a doctorate in pharmacy degree, as I just told, and extensive expertise in clinical and pharmacy practice. Formerly as an assistant professor at eminent Parul University, she has demonstrated a profound commitment to the research and academics. Dr. Suratiya is an author. She has already published one book named Drug Related Problems and Their Outcomes and Their Overcomes. And she has contributed to the scientific community with almost 12 publications, more than 12 publications in esteemed national and international journals. Her active participation in the national conferences, webinars, workshops, and panel discussions underscores her dedication to advancing pharmacy education. She also served as, one of the humanitarian during the COVID-19 crisis at Dheeraj Hospital. And she has envisioned transitioning from conventional supply-based pharmacy model to clinical skill-based service approach. So a lot to talk about her. But I'll come back to welcome you guys. So let me tell, we are starting the webinar, but we definitely have some rules and regulations. Okay, rules and regulations are not for everything, but for the attendance, because I get a lot of requests. People don't attend, or people don't fill the form, and then they come back like, sir, we didn't get the certificate. See, if you are not filling the attendance form, how would I know? Because there are 3,000 registrations. I or my team cannot give certificates to everyone who is just registering and not attending, right? So it is a very important issue, and it is a very concerning issue, guys. You have to be here with us at the end, somewhere around 15 to within 10 to 15 minutes. At the end of the webinar, we will share the one link, and you have to fill the form. And if you are joining in YouTube or Zoom meeting link, doesn't matter, anywhere you are joining, you will get the feedback form, you will get the attendance form, you have to fill that. And if you are missing it, then please, I'll not be responsible, frankly, because many people, because that some kind of excuse that we used to make when we were a student, right? Some people come that, oh sir, I just left 20 minutes back, I mean 20 minutes before ending of the webinar, or 10 minutes before ending of the webinar, my network was not working, I just dropped down, I didn't get it, I didn't notice, I was so, one person last time, not only one person, two three people came up with, like, sir, we were so much into the conversation that we forgot to fill the feedback form. We didn't notice the feedback form. Did you share the notice form? They were like, did you share the feedback form? We share almost 20 times. We shared in our conclave almost 20 times, and people come like, oh, we didn't notice because we were so much into the conversations in the webinar. So guys, please take care of that. This is a really concerning issue, because see, otherwise it is not fair with the people who are attending and who are really spending their time with us. So these conferences and workshops and conclaves, we are doing it free. We are spending a lot of frankly, money on the resources like Zoom meetings. It comes with almost 7,000 per month, and a lot of other things, a lot of logistics, lot of other things what we pay for. But we are just here to advancing the your career, your knowledge, your professional journey. So please, just at least think about the people who are joining us. There are 380 people in our webinar today right now. So that's really amazing. So, guys, I'll not take much time. I welcome you again. And with that, I would like to share one more thing with you before we go back to this. So, our course, you know that this course has already launched, and last date has gone through. Already, last date is over yesterday, and we got really amazing number of students. We got amazing number of students in this course, right? So this course is master certificate course in antimicrobial stewardship. This is a 4 months comprehensive training module, and here we will also have one major projects and multiple case presentations. So the real, this major project I'll tell you about, because many people have come up with this question like, sir, what will be the major project? So during this, course, after 1 or 2 months, we will share some topics. Okay, some topics we will be sharing, and you guys have to make one presentation on that and one report on that, 5 to 10 pages of word report on that. We just don't want you to learn this. Okay, and that is mandatory. Whoever is joining this course, this is mandatory to work on the project and presentation, because that will show your enthusiasm, that will show your dedication towards the antimicrobial stewardship. Okay, towards the, so we will provide some topics means based on the cases, and based on the real time scenarios, based on the policies. There are multiple projects. We already chosen around 10 topics for the projects. So people will be working on those topics, and they will be submitting the report. Okay, so those people, though, you will get enough time to go for the literature review, to work on the topic and all, and you will submit the project. Okay, that is mandatory for everyone who is joining the course. Okay. So along with that, I'll come to the part that why I'm showing this is because the date has already gone. Okay, date has already gone. If you look at the curriculum, it is comprehensive. You must have gone through this. I'll not show you that this is all. This is very much comprehensive. 4 or 5 pages of the syllabus. You can read the brochure. It's available in the website. It's available in our LinkedIn, everywhere, right? And so assessment and certifications also is there. So I just want to bring your notice to that last date is over yesterday, but especially because we couldn't conduct this webinar yesterday. We wanted to conduct this yesterday. We are conducting this today. So, keeping this in mind, we are extending our dates of this registration for 2 more days. I mean, today and tomorrow. So if you are interested, you can register for this course today itself, or maybe tomorrow itself. But I mean, tomorrow you can register. That's not a problem. But these are 2 days extension on a specific considerations, right? So if you are interested in this course, you attend the webinar. It's free of cost, no force, nothing. We are not forcing you to register to the course. It is just for the information. If you are interested in the course, if you find out this course interested to you, please join now, because this is the we are extending the dates for 2 more days for all of you, right? Okay, and I think that's enough from my side. And for this course itself, for this course as well, we have Dr. Neha Suratiya as the course director. She will be taking your classes. She will be handling all the things, and you must have seen her, knowledge and skills how she teaches in our recent course on pharmacogenomics. She has taken the 4 days classes on pharmacogenomics short course, right? So she will be, taking care of the entire course as the course director. She will be taking your classes, right? So, with that, guys, over to Dr. Neha, and over to you. And your mics will not be on until we finish the webinar. At the end of the webinar, we will open your mic so you can speak, and in between any time you can put your questions. Okay, we will take your questions, and I think that's all from my side, guys. Over to you, Dr. Neha. There are some questions for the course. If cannot attend live lectures, for how many days will be recording available? Recordings are available for, in our channels, so those will be available for almost a year. You can come back and check out those recordings. That's not a problem. This course is no, this course is for all PharmDs, pharmacy practice people,
Yes.
registered pharmacists, and everyone. Okay, this is for everyone. So if you are and MBBS, BDS, nursings, whoever wants to join, they can join this course. This is not only for PharmDs, but yes, for PharmDs, it is amazing. For PharmDs, it is amazing. Yeah, PharmD pursuing students can do.
Yes.
If you are in the third year, fourth year, fifth year, you can do it because it is knowledge enhancing. It has the pharmacology, it has the pharmacokinetics, it has every aspect of pharmacy practice. So, yeah, we'll take all the questions. You guys can mention your questions in the chat box. So, over to you, Neha. Please go ahead.
Okay.
Yeah, B
Thank
pharmacy.
you. Thank you so much for the introduction. And I'm very glad that people are taking part in the webinar in a large scale. So, okay, good evening, one and all present here. It is my again immense pleasure to welcome you all as we are going to introduce an exciting webinar today. Basically, we have so much to discuss, but we'll brief it out today that that will make you aware about what is the importance of stewardship and how we as a pharmacist can contribute in the antimicrobial stewardship, right? So it is very important again, and this particular program is designed to equip the healthcare professionals, the students, the researchers, and with the we can say essential knowledge and the skills to combat one of the greatest challenge in the modern medicine, which is antimicrobial resistance, right? It is my personal topic to discuss. And we can say antibiotic misuse and its overuse continue to drive the global crisis of resistance. Everyone will be agree on this, right? Making some of the infections very harder to treat. Sometimes it is impossible to treat because of antibiotic resistance, right? So, through this webinar or through those upcoming courses, you will gain the evidence based strategies to promote the responsible use of your antibiotics, which will further improve the patient outcomes and contribute to the public health effort worldwide. So we can say, and what makes this course very valuable is its core concepts, right? So we will be having the discussion on principles of antimicrobial resistance, like how it is working, how it is, having the impact on resistance, what is its global impact, what are the strategies for optimizing antibiotic use in the clinical practice setting, right? What are the hospital and what are the community-based stewardship programs which are already available? What are the policies? If you are a policy maker, this is very good opportunity, right? So if that what you can you should be aware of what are the policies which are already there, right? So policy development and its implementation of using antibiotics, we can say case based learning we are going to do, and a real world applications we are going to do in the upcoming course. So whether you are a healthcare provider, whether you are a student to advance your career, we can say, or you are a policymaker shaping the healthcare regulation, this particular course, upcoming course, is for you, right? So, to brief it out, we are having a webinar today to make you aware of how we, as a pharmacist, can, make an impact in this particular stewardship program. So let's get started. I will be sharing the screen, and I would like to request you all, if you found any query or any questions, you can put it in the chat box. We'll try to solve it as soon as possible, right? In between or in the at the end, we can discuss. You can unmute yourself and ask at the end of the webinar to discuss your queries. Okay. So I'm sharing the screen. I hope the screen is visible.
Yes, Neha, please go ahead. Yes.
Okay. So this webinar has a title, Core Principles of Antibiotic Stewardship, right? And particularly in this session, we are only focusing on the three main learning objectives, and those are the optimal antibiotic use. Now, when we say a optimal antibiotic use, that means in an antimicrobial stewardship, particularly is the selection of the best possible antibiotic, best possible dose of it, and the best possible duration to treat, because very important is the duration of therapy, which is the third point to discuss. Because no one can be having the very good experience with the long term taking the medicines, right? So basically choice is very prominent. We can say a very best possible antibiotic with its dose, with its perfect duration to treat or to prevent infections. And it also involves minimizing the risk of antibiotic resistance and harm to the patient. So that is the optimal antibiotic use. Next, in another word, we can say optimal antibiotic use is a rational use of the medicine or a quality use of medicine, we can say, right? So right time, right dose, right duration at a right cost. I think that right, that is a rational use of the drug, right? So this is the optimal antibiotic use. We'll see what it is in detail. Next point we have, that is the de-escalation strategies. Now what is it? Basically, de-escalation strategies are starting with the broad spectrum and then narrowing it, right? Moving towards the narrow, because once you have identified the particular pathogens, now you are able to target more specifically with your treatment. So basically in the antimicrobial stewardship, the particularly de-escalation strategies refer to the practice of initially starting a patient on a broad spectrum antibiotic to cover the wide range of potential pathogens, but then narrowing it, okay, narrowing the antibiotic regimen to a more targeted, more narrow spectrum therapy once you have the cultural result, which are identifying the specific bacteria which are causing the infection, or a specific viral you can have, right? So when you have a specific cause of it, now you have a particular target, and then you are narrowing your spectrum. So this is basically a de-escalation, and we have multiple strategies to do it. The very popular is IV to oral, right? So those can be objective of our understanding of antimicrobial stewardship. And we can say this particular de-escalation strategies minimize further the unnecessary broad spectrum antibiotic use. Further, it can minimize the adverse drug reaction, which is very common with the broad spectrum antibiotics, right? And again, it can reduce the risk of antimicrobial resistance, which is very common problem with it. Okay. And next learning objective we have, that is the duration of therapy. So in antimicrobial stewardship, the duration of therapy, which is refers to the length of the time a patient should be treated with an antibiotic. So basically it is a time like a 2 months, 6 months, 4 weeks, whatever it is. But we all know that duration of therapy should be short and your therapy should be effective, right? So this is the key focus in minimizing the unnecessary antibiotic use for the prolonged period of time, and it is promoting appropriate treatment duration, right? Often aiming, we can say, to shorten the courses whenever possible based on evidence-based guidelines, but obviously, and the specific infection which is being treated. Okay, so typically with this means duration of therapy means prescribing the shortest effective course of antibiotics to achieve optimal, we can say a maximum clinical outcomes while limiting the risk of resistance and adverse drug reaction. So this is how the learning objectives are defined for today's webinar. So we'll see one by one, that is what is optimal antibiotic use, how we can use it, what are the strategies to implement it, what are the de-escalation strategies we are having in the clinical practice setting, okay, and how we can achieve this duration of therapy goal, right? So this can be our learning objectives. Let's start. Okay, let's understand first the overview of antimicrobial stewardship. First of all, we'll start with the definition. So, antibiotic stewardship, again, it is referred to a coordinated strategy. See, this is not a single term, this is the umbrella term, right? So, it consists of coordinated strategy, right? Which is aimed at optimizing the use of antimicrobial agent. Here, the meaning of optimizing meaning a maximize, okay? To improve the patient outcomes, We all are in a clinical setting where we are aiming for improving patient outcome, reducing our resistance. After COVID-19, everyone are aware about it. What? That resistance is a very big problem in healthcare, right? So see, this azithromycin and the some other tablets are not having any effect now. So resistance is the biggest challenge to face when it comes to the antimicrobials, right? And another aim is to minimize unnecessary side effects with the broad spectrum, right? So this is the stewardship definition, antibiotic stewardship definition. In another word, we can say AMS, which is the antimicrobial stewardship, which is particularly a program that promotes this particular objective, right? So it promotes the proper use of your antimicrobials, like all other antimicrobials, biotics, antifungal, antivirals, etc. And the goal of this antimicrobial stewardship is to improve the patient outcome, reducing the spread of infection and decrease the ultimate resistance, right? You can see here the use of antibiotics are very, in a large scale it is happening, and unnecessary side effects are there which can worsen over the time. So that it is very important to understand how we can contribute in the field of resistance, right? Let's understand what can be the another factor. So the goal of our antimicrobial stewardship can be enhancing our clinical outcomes. Very important. Okay, we are aiming for the enhancing clinical outcomes, minimizing the resistance, of course, reducing healthcare cost. As I earlier said, if you are having aim of rational use of the drug, this will be having a clear idea of right time, right dose, right agent, right duration, and with the right cost, then it is rational, right? So this is basically healthcare cost associated with the prolonged hospital stays and its complication. So our goal is all covering it all and prevent our adverse drug effects, which is the biggest drug related problem. Okay, let's understand what are other factors of antibiotic stewardship. So we are having a very first enhance this. See, these are the parameters of antibiotic stewardship because it is an umbrella term. So you are focusing on enhancing infection prevention and control. You are focusing on controlling the source of infection, which is basically a cause of it, right? You are focusing on prescribing antibiotics when they are truly needed. So unnecessary antibiotics are prohibited in that case. Prescribing appropriate antibiotics with adequate doses, the right dose, the right drug, right? Using the shorted duration of antibiotics based on evidence. Okay, so no one is having, the uh, no one is enjoying the long term medication treatment. Okay, so this is very important, duration of therapy. Also, reassessing treatment when culture results are available. So once you are started with the broad spectrum and then the culture results are there, and then you are shifting your regimen towards the narrow spectrum, which are more target oriented, right? So there is a de-escalation and assessing further when the cultural tests are performing. Reassessment is must, right? Next, we can say the parameters supporting surveillance of AMR and hospital acquired infection, because which is very important. Antimicrobial resistance is another thing, and hospital acquired infections are the another things, right? Because in country like us where the HIs are very very popular, okay, you can say UTI, pneumonia, tuberculosis, those are the highest percentage of hospital acquired infections a persons are having, right? So monitoring of those, surveillance of those, and monitoring of antibiotic consumption with it, that is also a part of your stewardship program. Another thing is education. So your staff should be having enough knowledge of antibiotic stewardship, the guidelines, the policies, and how it is going to be implemented. Okay. Next, we have supporting interdisciplinary approach. So in this case, we have an interdisciplinary approach. Everyone should be connected under the same umbrella and working forward with the patient care, right? Okay, let's understand further who can be the key stakeholders in this case. If you are talking about antibiotic stewardship, so physician, pharmacist, nurses, so infection control specialist, member of the committee. Okay, hospital are having a different committees, and one of the committees are the infectious control committee, where the specific position is there, which is the infectious control specialist, right? Those can be the key stakeholders, public health agencies and policy makers, because we are going to discuss about policies which are are already there on the use of antibiotics. Okay, patient itself and their caregivers are also having a stakeholders. So this is very important to know. So ऐसा नहीं है कि some of, if you are a nurse or if you are having another background, you cannot relate with the antibiotic stewardship. This is the particular term, everyone can relate with it. Every healthcare professional has relation with antibiotic stewardship, right? Everyone has role in it. Let's understand what can be the reasons for antibiotic resistance first of all. That can be a misuse, that can be a overuse. So that might be a number of reasons. But let's understand what can be the broadly we can discuss. Okay. Very first is overprescription and inappropriate use. That is basically misuse or overuse of particular agents. You might be having idea every prescription has multivitamins in it, right? We can understand that some medicine has effect to decrease the absorption of certain vitamins in the GIT, but trust me, not all patient requires all the multivitamins all the time. So basically this is over prescription example, right? So antibiotic prescribed for viral infections like the common cold or flu, you can say prescribing antibiotics for the common cold or a flu and taking antibiotics whenever they are needed by the patient, that is over prescription or inappropriate use of the medicine, right? Next we have use of broad spectrum antibiotics when narrow spectrum options would suffice. There is very again very common problem to understand, because you will see a prescription and you will find this thing, if the narrow spectrum is suitable, still the broad spectrum antibiotic is given because of certain beliefs, right? Again, empirical therapy without proper microbial identification. So what is empirical therapy? So empirical therapy is a medical treatment which is based on the experience, we can say, and an educated guess. We can say the another word, right? Rather than complete information, you are rely on the evidence based things, right? And it is used when there is not enough information to identify the exact cause of the illness. So that is empirical therapy. But it is without proper microbial identification. If it is going to be happen, then again it will be resulting in inappropriate use, leading to antimicrobial resistance. Another reasons can be patient related factor. Now this is very understandable. Self medication and incomplete antibiotic courses in country like us, if you are having a pharma background, you might relate with my words. When we say when we sit in the DIC, will we always observe patient are taking self medication. You know, everyone is having a doctor degree in itself without a degree. So हाउस रेमेडीज करते हैं, राइट, सेल्फ मेडिकेशन करते हैं, एंड इन हमेशा जो ठीक हो जाते हैं उसके बाद एंटीबायोटिक कोर्सेज को ड्रॉप कर देते हैं. सो दोस कैन बी योर पेशेंट रिलेटेड फैक्टर रिजल्टिंग इन अगेन inappropriate use. Pressure on healthcare provider to prescribe antibiotics unnecessarily. So patient having that sense of telling the doctor that I am particularly addicted, I am particularly wanting particular agent to treat my disease, so write me those only. Okay, so these are also the things, pressure on the healthcare providers sometime. This can be the patient related factors that can be result in inappropriate use. Next, we have the reason hospital acquired infection and transmission, as I earlier said, very important, which is cross infections due to improper hygiene and sanitation. Very popular example, UTI. Okay, urinary tract infection because of poor hygiene and sanitation, HAI की category में आता है, and sometimes pneumonia, tuberculosis, that can be again respiratory tract infections, can be transmitted because of poor hygiene and sanitation. Prolonged ICU stays with extensive antibiotic exposure, that is also hospital acquired infection category. Okay. Next reason we have for the antibiotic resistance, that is the lack of awareness. And that's the only reason in previous slide we have one parameter of education of staff as well as public, which is very important, right? So poor understanding of antibiotic resistance among the healthcare workers and the public, that is also our very big reason to end up with the resistance and misuse, right? But these are some these are, we can say, modifiable reasons are there. We can control over this four types of reasons, right? Okay, let's understand another things are basically first is the optimal antibiotic use strategies. Now what it is? First of all, a right drug with the right dose, with the right duration, rational use of the drug, okay, quality use of the medicine. Basically, selection which is based on your patient's culture and sensitivity reports, dosage adjustment based on their renal and liver function and sensitivity of infection. This is called a personalized medicine concept, right? So basically, patient is more suitable towards the particular agent and not following a traditional practice of prescribing. This is what the optimal antibiotic use. Okay, let's understand another thing, use of narrow spectrum antibiotics whenever possible, reduce the collateral damage to the microbiota. That everyone can be agree on the point, that use of narrow spectrum antibiotics, because broad spectrum antibiotics has another adverse drug reaction, and if the patient is not having any of the target, okay, for the broad spectrum, then it will having unnecessary use of antibiotic, okay, leading towards the ADRs. Next, we have adherence to clinical guidelines and protocols. We have n number of clinical guidelines and protocol. In detail, we have the syllabus in our upcoming course, that what can be the clinical guidelines and protocols we have to adhere on when we talk about antimicrobials, right? So implementation of those hospital or national guidelines on antibiotic use, regular updates is also mandatory based on emerging resistance pattern, because in every week they will have a update in resistance pattern, right? So it is very important to get the update on it. Combination therapy in selected cases used for the severe infection like sepsis or tuberculosis, but please avoid when it is unnecessary. You will see doctors are there, many healthcare professionals are there who are having a same traditional practice of prescribing the same medication chart towards the patient, right? So this is not the practice. This is the only reason we end up with the resistance and unwanted effect of the medicines. Role of diagnostic tool, use of biomarkers like procalcitonin. Now, this procalcitonin, also known as PCT, which is a blood test that measures the level of protein, right? That help to identifying the bacterial infection. So it can also help to guide your antibiotic use. So very important to understand to use the biomarkers like procalcitonin to differentiate if the patient is having antibacterial infection or antiviral infection, right? What we are aiming at. So if the patient is having bacterial, we are supposed to give the antibiotic. If the patient is having viral, we are going to introduce an antiviral agent, right? So these can be done. Rapid diagnostic testing for precise therapy can be done. So these all are the aspect of optimal antibiotic use, right? See, this is the another parameters that has link with the optimal antibiotic therapy. Very first is adequate microorganism coverage. Okay. Adequate time of first antibiotic dose. So that is very important, loading dose. Correct route of antibiotic administration. So what can be the correct route suitable for particular patient? Okay. Correct antibiotic dose, which cannot be high. Okay. Next, we have immunomodulatory effect of antibiotic. Very important concept, immunomodulatory effect. Okay, means that they can, we can say influence, or they can modify the immune system. Okay, either by, we can say, suppressing your excessive inflammation, or we can say promoting balanced immune response, or the another thing, that those are the directly affecting immune cell. Okay, immune cell function. So those can be your immunomodulatory effect of your antibiotic. So as a healthcare professional, you must be aware of your antibiotics effect, immunomodulatory effect. Okay, so often it is observed, very popular agent azithromycin, okay, macrolide antibiotics, which can help to regulate your inflammatory responses in certain conditions like respiratory diseases, right? So again, this is the immunomodulatory response, okay? And with that, you have to be aware of your pharmacokinetic characteristics, okay? What body does to the drug and how the antibiotic is getting digested, right? All of these factors are having a very direct relation with the optimal antibiotic therapy. When you observe these parameters and when you have clear idea while delivering the medication to patient, then it is known as optimal antibiotic therapy, and that might further decrease your mortality risk, which is our aim, right, as a healthcare professionals. So this is very important to understand. Okay, how it can be achieved? What optimal antibiotic use? How we can achieve it? So we have some of the ideas. First, we have evidence-based interventions. So always use the evidence-based interventions to support the selection of your best antibiotics. See, we have included one by one, in detail this point in our upcoming course with the practical scenarios, that what is the evidence-based intervention. When you have the previous data, when you have electronic health records, you can intervene these things, and by seeing those results you can further evaluate that what particular patient is seeking for, okay, and how we can modify your optimal use of antibiotics. Next, we have antimicrobial stewardship program. Implement programs that improve your antibiotic prescribing. Those can be having policies, guidelines. Okay, uh, guidelines are there to follow treatment charts, right? So those can be again helpful. Certain policies are there. Specify policies are particularly specifying the dose, the duration as per their age. Okay, so adult, if the patient is adult, what can be the policy? Okay, if the patient is geriatric special population hai, then what can be the policy? Okay, policy meaning specific dose of it, how the dose calculation occur. Okay, what can be the duration suitable for the particular patient, and indication, we can say, for the documentation also. The policies are there to document those things. So those can be ideas to achieve. Next, we have facility specific treatment. Okay. Now this facility specific treatment is using of specific antimicrobials in way that optimizing a microbial killing. So basically, this word is very confusing sometime, but it is facility specific, meaning complete cultural test and examination should be done before prescribing anything. And then change in the therapy should be there, de-escalation should be there, right? Next, we have pharmacodynamic dose optimization. So you can also use your pharmacodynamic profile and pharmacodynamic information to further optimize your dosage calculation as per the patient's need. So when you combine policy, when you combine certain program data, when you combine evidences which is on the basis of previous studies or electronic health records, and when you study your pharmacodynamic data, right? And all of this combines, then you can achieve optimal antibiotic use. See, practically speaking, every time achieving optimal antibiotic use is not practically possible. Okay. But we as in healthcare professionals can always try our best to achieve optimal antibiotic use. Okay. So please do not think like that ki, if it is not working like that, it is wrong. Okay. So ऐसा नहीं है, but this is difficult, but it is not impossible. Okay. We can work on it. Just want to learn that how. Okay. Okay, let's understand the de-escalation strategies. Very important topic of today's webinar. De-escalation. I already explained you the definition of de-escalation. It is starting with the broad spectrum, and then after you have the cultural examination results, then you can further narrowing your spectrum and you can be more target oriented, right? So this is basically a de-escalation as it name suggests. So first of all, in which we are having an initial broad spectrum therapy, which is the empiric therapy, of course, which is used in the critically ill patient while awaiting the cultural results and chosen based on the local antibiogram and the patient's history, right? So once you have the local antibiogram data and the patient history, you are starting with the broad spectrum, first of all. And once you have the cultural result, then you can de-escalate further. Let's understand microbiological data driven adjustments. Okay. Basically, once the pathogen is identified, right? If it is a bacteria, if it is a virus, and which category of bacteria, gram positive, negative, etc., then you can shift towards your narrow spectrum antibiotics. Stopping, we can say, redundant or ineffective therapy, which is not necessary once you have the cultural result. Okay. So discontinuing unnecessary combination therapy, and route of administration also changes. For example, IV to oral switch, very very important topic. If I want to discuss a IV to oral switch, I think I want a whole 1 hour to discuss IV to oral switch, how we can switch from the IV to oral with, well, how we can calculate dose. And this is the topic of actually TDM, but very important to learn. Okay, this can be done in case of de-escalation to reduce your hospital stay and your complications further. See, this is the very good diagram to understand the strategy. You can see here on the day zero on the left side, you can start your broad spectrum first of all. Once you have culture result, you have identification of causative agent, and you have some antibiogram, whether it can be local or generic, right? And if you have, and you have a complaint of patient, history of patient, chief complaints, right? So further on evaluation of those by day 1, 2, 3, you can continue your therapy, you can escalate, or you can de-escalate further. Okay. And after day 5 to 7, you can stop. So this is the we can say a pivotal antimicrobial, okay, which is basically change in the spectrum based on patient's requirement. Very important to learn. If I want to discuss this particular diagram and this slide, it is having a very in detail things. So we'll cover these things in the upcoming course, and this is very brief things to understand. Okay. De-escalation. Let's understand what is important here is, as a healthcare professionals, we should understand the definition of it. Okay, so basically this is the definition of a very particular program in the antimicrobial stewardship, which is basically referred to the practice of initially starting patient on a broad spectrum antibiotics to cover a wide range of potential pathogens, but then quickly switching to a narrower spectrum antibiotic once the culture results identify the specific bacteria causing the infection. Thus, what we are aiming at, minimizing unnecessary broad spectrum antibiotic use, right, which is our aim, and reducing the risk of antimicrobial resistant development. And this typically involves reviewing your culture results after a few days and adjusting the therapy accordingly based on identifying a pathogen and its susceptibility pattern. So this is a very good understandable definition of de-escalation strategies. Okay, we have a number of it. We'll see what are the key aspects of it. Let's understand what can be the key aspects in de-escalation strategies. Okay. Very first, we have early culture collection. Basically, collecting your specimens for a culture and sensitivity testing as soon as possible after initiating a empirical therapy. Once you have introduced a broad spectrum antibiotic to the patient, as soon as possible, you have to collect the culture collection. Okay. Next, we have reviewing culture results promptly. Okay, so regularly monitoring culture reports to identify further the causative organism and its susceptibility pattern. Reviewing it correctly is also a key aspect of de escalation. Narrowing the spectrum further, so once the pathogen is identified, switch to a narrow spectrum antibiotic that is specifically effective against the specific organism. So this can be your key aspect. Next, we have discontinuing unnecessary antibiotics, which can be your broad spectrum category. So if your cultures comes, we can say comes back negative, then consider stopping the antibiotic altogether if it is clinically appropriate. Okay. Next, we have monitoring of clinical response. You should closely monitor the patient's clinical condition to ensure the de-escalation therapy is adequate. Because in some time, what happened that some viruses are there that cannot be detected, as easily. So in that case, patient may be deteriorate further. So this is not as easy as it seems. This is very hard technique to implement de-escalation. You need to have a much number of case studies to do it. So we'll in upcoming course we have the real world application and case based scenario where we'll discuss that how uh, practitioners are practicing the de-escalation strategies in real world. So we'll see some cases, we'll give you exercise of if this is the scenario, how you can de-escalate the therapy further. So those are the things we'll discuss in the upcoming sessions, right? Okay, let's understand. See, these are again the very important tools to understand of duration of therapy. Okay, so those are the duration of therapy consideration. See, duration of therapy, I already explained you what it is. No one is wanting a more prolonged period of taking medicine. So it is basically a shorter versus longer course. And evidence supports that shorter courses, for example, 5 to 7 days of antibiotic for most of the infections avoiding unnecessarily prolonged therapy that reduces the resistance and the side effects. So this is very important to learn duration of therapy. Individualized treatment duration, adjusting your adjusting your dose duration based on patient's response, based on patient's biomarkers, right? Those can be the procalcitonin, for example, and the clinical improvement. And post treatment monitoring also can be done to ensuring the reoccurrence doesn't occur after stopping your antibiotics. So follow up your cultures and patient reassessment, that is also your part of therapy. So basically we can say in antimicrobial stewardship, the duration of therapy refers to the recommended length of the time a patient should take antibiotics, which is typically aimed to be as short as possible while still effectively treating your infection. So often it is focusing on durations between 5 to 7 days for many of the common infections like common cold, flu, certain viral infections, right? With the goal of minimizing your unnecessary antibiotic use and reducing your resistance. So this is basically a duration. But once you identify, the optimal antibiotic use, considering all those parameters which in previous slide we have discussed, and once you identify the de-escalation strategies, that how we can do it, targeted therapy you are introducing into the patient's prescription, then and then you can modify your duration of therapy. Okay, so this all has one link. Okay, let's understand further key points about duration of therapy in the antimicrobial stewardship. Obviously, shorter is always better. So, modern practice emphasizes using the shortest effective duration of antibiotics for most of your infections to minimize unnecessary exposure and potential for resistance development. Long term treatment might be having a n number of resistance pattern, right? Because our body is a very complex mechanism it is having, and those can be adjusting, your body has a adjusting mechanism. They can be adopted the mechanism which are directly having link with the antimicrobials mechanism of action. So those can be result in resistance, right? Evidence based guideline you should follow, and guidelines ka update bhi, right? So healthcare providers should consult established guidelines from organizations like Infectious Disease Society of America to determine the appropriate durations for specific infections. So what can be done here? You should be aware with the physician that what is the appropriate duration of therapy for particular infections, okay, to control it. And what can be the factor which can be influencing your duration of therapy? First of all, severity of infection. So more severe infection might require larger course of antibiotics, okay, without a doubt. Type of bacteria, very important. Different bacteria may require varying treatment duration. See, we have identified a lot of bacteria in recent world, but still there are many to to still be discovered. So those can be the again factor influencing. And patient related factor, for example, underlying concurrent medical conditions and immune status of the patient, that can impact the treatment length. That is understandable that patient related factors are also there to influence it. So those are the key points and the factor influencing it. Very important thing is this: how antimicrobial stewardship promotes optimal duration of therapy, how it can be done. So basically a proactive review of antibiotic prescription that can be done by us, okay, healthcare professionals, reviewing patient charts to identify a potential cases, we can say, of overprescribing or unnecessarily long antibiotic courses. So you can always review proactively that what is the reason behind it, right? De-escalation, so initially broad spectrum and then switching to narrow spectrum antibiotic once the bacteria causing the infection is identified. And the patient education, informing patient about the importance of completing the full course of antibiotics as prescribed even if they feel better, okay? Because this is a very traditional practice of leaving the course in between once the patient has patient felt some recovery. So it is very important to give the patient education. See, these are the challenges to overcome in case of antibiotic stewardship, okay? So you should be reform, you should be integrate, you should be developing easy to use guideline and following the easy to use guidelines. Harness existing relationship between formally and informally trained providers, systematically train and produce primary care providers in inadequate numbers because staff is also mandatory, and balance of pharmaceuticals promotion and expansion with antibiotic stewardship practices. These factors are challenges, but it can strengthen your antibiotic stewardship in the community settings, right? Let's understand one by one what can be the challenges are there to overcome, right? See, these are very basic to understand, but once you have idea of what can be the challenges in antimicrobial stewardship, you will be next time having a sense of it, right? So you will be having idea that how the challenges are there and how we can overcome it. Very first is the institutional challenges, basically a lack of dedicated stewardship team. We can say many healthcare settings, especially resource limited areas are there. Okay, so that is a lack of dedicated team. Okay, lack of a formal AMS team, uh, consisting of infectious disease specialist, microbiologist, and pharmacist. So that should be there. We have another is inadequate funding. So AMS program required financial investment in personal, in we can say diagnostic tools, and in the data management as well to maintain your electronic health records. Okay, which may not always be prioritized. Next, we have limited access to microbiological testing. Obviously, because many healthcare facilities, especially in the low to middle income countries, we can say, lack access to rapid diagnostic tests and antibiograms, delaying your appropriate antibiotic choices. In case of COVID-19, you can imagine, right? Poor integration of AMS into hospital system, which is again lack of electronic health records and clinical decision support system, which is CDS, double S, which is very important to learn, makes monitoring antibiotic use again difficult. Okay, poor integration. So this is again institutional challenges. Next, we have clinical challenges, which we can modify. Okay, institutional challenges are not in our hand, but the clinical challenges we can modify, right? First, we have empirical prescribing and overuse of broad spectrum. So, due to delays in cultural results, clinicians often, prescribe broad spectrum antibiotics empirically, leading to again unnecessary exposure of antibiotics. So if you are aware about it, you can further modify or suggest the practitioner or a physician. Fear of treatment failure, physicians may hesitate to further de-escalate when the microbiological data suggest it is safe, fearing the patient's deterioration. That is also a fear of treatment failure. Next, we have high burden of multi-drug resistance infection. So basically, high burden of MDR infection, which is again very important. So it is a rise in MDR pathogen, which is if limits the effective choices of antibiotics, making a stewardship more complex further. And we have complexity of de-escalation and shorter duration strategies. So clinicians may struggle with the deciding when to do a de-escalate and when to stop therapy, particularly in the very ill patient, right? So that's where the pharmacist stand. That's where the another healthcare professional stands. You are there if you are aware about it, antimicrobial stewardship guidelines. If you are following its principle, that's where the importance come, right? You can suggest here that how the de-escalation takes place and how we can do it, okay, collectively. Next, we have behavioral and cultural challenges. For example, lack of awareness and training. Many healthcare workers we have in our settings that has the insufficient knowledge of antimicrobial resistance and stewardship principles. So those can be the lack of awareness. Pressure from patient and family. So in some cases, patient demand antibiotics even for the viral infection because they are having the idea of particular वो येलो कलर की पील वो पीली वाली गोली से ही ठीक होता है. So those can be the again the behavioral challenges we have to understand. Inconsistent adherence to guidelines, variability in clinical practice, we can say guidelines which are across the institution that can lead to inconsistent antimicrobial use, and biggest challenge over the counter availability of antibiotics. Okay, so in many countries antibiotics are available without prescription, including India, contributing to widespread of misuse. Okay, biggest challenge it is. Next, we have global and policy challenges. For example, regulatory gaps, and lack of national stewardship. So, again, many countries lack this strong regulatory framework to control the antimicrobial prescribing. Okay, so those can be again lack, okay, or a challenge to overcome. Then agriculture use of antibiotics. Again, widespread use of antibiotics in the livestock contributes significantly to antibiotic resistance in the human pathogens. Next, we have limited development of new antibiotics. Everyone can be agree with it that pharmaceutical companies invest less in antibiotic development due to the lower financial incentives compared to other type of category which is not antibiotic. Okay, so those can be again our challenge. And inconsistent surveillance and data collection, lack of centralized AMR data. Okay, antimicrobial resistance data, because we need to address this issue. We need to have electronic health record data collection. Okay, and those can be your evidence based solution of it. Okay, so that can be hinder the monitoring and response the effort at the national and the global level. So this is again the challenge. So those can be the four different stages of challenges, that can be of institutional, that can be of clinical challenges, that can be of behavioral or cultural challenges, and global and policy challenges to overcome when it comes to antimicrobial stewardship. Okay, possible solutions to overcome. How we can do it? Strengthening your hospital stewardship team, okay, with a dedicated person in it. Expanding your diagnostic capabilities, including a rapid microbiological testing. So this is very important. Implementing electronic decision support system. As I earlier said, we need to have electronic decision support system to guide further the antibiotic prescribing. Increasing public and healthcare professional education on resistance, because some persons are not having idea of resistance. Okay, enforcing a strict regulation on OTC antibiotic sales and agricultural use. That this is very important. Lots of people are having talk on this restriction and regulation of OTC, but I think we didn't seen, we haven't seen anything in past few months, we can say, of regulation on OTC, right? It is easily available, which cannot be sold without prescription. We can say incentivizing the pharmaceutical companies to develop more novel antibiotics, because they are always having another thing to discover. Establishing global collaborative effort to monitor resistance trend and share the best practices possible. Okay, so those can be your possible solutions. See, this is a very brief webinar on antibiotic stewardship. Each and every slide, if we want to discuss, it will be a whole complete different lecture. Okay, 1 hour. So please understand the depth of antimicrobial stewardship. So we can see what can be the conclusion and future direction in this. So the need for global coordination to combat your antibiotic resistance, strengthening your education and awareness for both healthcare providers and the public. So if you are having a background of healthcare, and if you are not aware of de-escalation strategies, you are not aware about antibiotic stewardship policies, guidelines, and how it is going to be implemented, this is not the practice. Investing in new antibiotic development and alternative therapies, for example, bacteriophage therapy or probiotics, for example, and implementation of antibiotic stewardship programs at local, national, and global levels. Okay, so we are here to give you all the details on antimicrobial stewardship. That okay, we have a comprehensive course on it. See, to know more about antimicrobial stewardship, this is the course we have, and another 2 days, I think we extended our date to for this course. You can see the very important part of this course is it is affiliated with the reputed university. Okay, uh, that is the Gitanjali Institute of Pharmacy. So it makes it valuable, right? And the core concepts are there to discuss. See, this is the course curriculum, which is very comprehensive in it. These are
Yes,
the
yes, absolutely.
another
Yeah, yeah. Please go ahead. Please go ahead, Neha.
yes, these are the another 2 pages of syllabus. Have you seen of 8 pages of 7 to 8 pages of syllabus of courses, right? That is completely defined. See. So whether you are healthcare provider, student, if you want to do this course, this is for you. Don't miss. I think I would like to request that don't miss this chance to be a part of the movement that protects the future of medicine. So at the end, I can say join us, learn and lead the change in the antibiotic stewardship program. Okay. So if once you completed this course, if someone is asking you that what is stewardship, uh, we are assuring that it will be having a clear idea of how it is going to be happen. See here, the future direction and emerging trends are also there to use of artificial intelligence, how we can use AI and machine learning in stewardship. This is also there. In today's webinar, we only discuss about brief ideas of how we can achieve optimal use of antibiotic, how we can contribute it, okay, what is de-escalation, which is very brief and which is very superficient. But we can go in detail if you guys have interest in it, okay? So thank you so much.
Yes, thank you very much, guys. And yes, so I would like to say that if you are interested, please join. I have shared the link of the course as well here. And guys, as Neha said, it is a wonderful course. And not only CliMed is, giving the credentials, but you will get the credentials from the university as well. This is the university affiliated course.
Oh, yes.
Okay. This is the university affiliated course, and you will get all quality content, right? All quality content. That's why, we are requesting you. The price of this course is really, we kept at the minimum cost. Minimum cost, we kept the price of this course. Okay. So if you are interested, you can definitely register, and we have, extended the dates of registration for today and tomorrow. If you are interested, please join. Okay. And I have shared the feedback form. Please fill the feedback form. And along with that, I would like to invite you for Thursday also, guys. We have one of the another topic from the same course on Thursday. Okay. We are coming up with one more webinar, free webinar with certificate, because we always understand your time. So the from the same course, we will take one more amazing topic, and we will be coming up with a free webinar on Thursday evening 7 p.m. Okay. Thursday evening 7 p.m. Be ready, and you will get another wonderful topic to learn from us, right? And Neha will be taking the webinar. So, Dr. Neha, we have some questions
Yes.
from you and from Zoom. Can you please check out in the Zoom? I'll
Yes.
just see what in the YouTube. So we have shared the feedback from everywhere. Okay, there are some questions. I'll see. First, I'll take the YouTube questions. How to reduce the resistance in children from same drug prescription? Okay, Ravindra Patil is asking
From
from YouTube.
same drug prescription.
Yeah.
See, for the pediatrics, you have different guidelines, right? For pediatric population, you have complete different dosage adjustment, dose calculation, because it is having a special population category. So for this, you have to be very clear with the body surface area and their weight, and you have to calculate it further. And that's when you go into the pediatric ward, you will see the antibiotics which are used in the cases of pediatric population. Then you will be having idea of how they are calculating it, right? So yes, it is possible to reduce the resistance in pediatric, but specific with the specific guidelines. Okay, what is regulatory gaps? See, regulatory gaps meaning we have certain guidelines, policies, and we have certain things to follow if we want to restrict the resistance, right? But in that case, also we have gaps, basically, which means resistance is day by day increasing, and some of the new patterns are also, arriving. So we have to understand that there is always a gap in regulatory things. Okay. So once you know what is the policy which is already established, you will see the gaps in it. Okay. Sir, you are not audible.
Yes, I'm so sorry. Yeah, so Sweta is asking about can I get a few antibiotic resistance cases for my final year project work? Definitely, but this
Yes.
is just the web. We cannot help you right now. You have to join the course, so you will get a lot of things on that. Okay, on what basis the antibiotic therapy will be given to a patient? I think that's already discussed. How we know about which drug has cross reaction or adverse effect of each other. Okay,
Sir, can
in
you please
simple,
repeat?
sorry,
What was the question?
how we know about which drug has the cross reaction.
See, we cannot assume that the drug is having cross reaction. We can, we have the adverse drug reaction category. So when you see that the patient is suffering from any unwanted reactions, then you can identify the cross reactions of particular agents,
And
right?
definitely TDM will help. Yeah,
Yes, TDM will help. We cannot assume the things.
yeah. In your opinion, how would practical scenarios may hold back optimal use of antibiotics?
Practical scenarios of what?
Yes, Vaishnavi, can you please write further? Okay, so by the time we can take the questions from a Zoom meeting.
Yes.
Will this course help me identification of Mediclaim investigations? We'll go from down to up. I think this is a very good question.
Will this course help in identification of Mediclaim investigation? Mediclaim investigation, in sense of what? Like if you want to know that how the Mediclaim investigation is happening.
Fraud medical investigations, Mediclaim. I think his question is he did not put the question in right way, but I believe he's trying to understand that if someone is admitted in the hospital and
Hmm.
hospitals do use the antibiotics irrationally,
Hmm.
and they claim for the
Mediclaim.
medical bills or insurances unnecessarily. So is it possible to understand that by the antimicrobial stewardship program?
First, we'll try to cover that what actually the antibiotic stewardship is, because we need to start from basic. This is the question which is, we can say advanced level. अगर हम बात करें तो ये बहुत बात की बात है that how we should investigate further those problems. But in this course particularly, we'll start with the basic and we'll try to move further. So I cannot say that Mediclaim investigation I will put into the course, but yes, you will have that idea ki in that possible way you can identify that how the Mediclaim investigation takes place in that case.
Yes, absolutely. Okay, any other questions, guys? Okay.
You are asking questions of therapeutics, which, after learning in the course, you will be having clear idea of TDM and therapeutics, that how it is going to be helpful.
Yes, definitely. Okay, can you please explain project part of the course? So as I told you, there are some topics. We will give you some topics on the real based, real time case scenarios and real time policy makings. You have to go back, you have to search for the literature, you have to check out the, papers, you have to check out the policies, and then you have to make the report. Okay, including cases. We will, tell you about the cases as well. So don't worry about that. Okay. So you will check all the things in that. Okay. So project means you have to prepare a report of 5 to 10 pages and you have to prepare the PPTs to present. And that is a mandatory part of the course. Okay.
Which
Oh,
antibiotic required therapeutic monitoring? Okay. See, all the narrow spectrum antibiotics required therapeutic drug monitoring as their therapeutic index is narrow. Okay, what do you mean by therapeutic index here is your maximum safe concentration and minimum effective concentration range, right? So once the range is very narrow, then it requires TDM.
We'll take the questions. I think we left a lot of questions before. Guys, if you have questions, please repeat that. If we missed it somewhere, perfect slide. Okay.
Does the wrong choice. Yes,
Hmm.
the wrong choice of antibiotic can lead to resistance. It may or may not, but it will lead to ADR
Definitely.
definitely, right?
Is there any criteria for choosing broad spectrum antibiotics?
See, there are multiple guidelines, okay? In the course curriculum, in one session, we have included those things like guidelines to follow how to choose a broad spectrum antibiotic based on the condition which is suitable for the patient.
Someone has right in two DOC of particular bacteria. So, in that case, how we choose one out of two? Okay. Can we move directly to narrow spectrum antibiotics if we are able to identify microorganism through pathological test?
Yes, of course. But once the patient is having chief complaint and once it is, he or she is visiting the clinic, first of all, based on their clinical identification and chief complaints, the broad spectrum antibiotic is given. And it takes 1 or 2 days to check further the cultural test and examination. Okay. So this is how the practical scenario is.
Yes, absolutely, absolutely. And what's the regulatory gaps? Okay, we will, I
I
think,
already
take,
explained, yes.
yeah, what is more prone for resistance, either incomplete short course or longer duration course? Okay, I think this is a good question. Which is more prone to resistance, either incomplete short course or long duration of the course? I think you have discussed that as well, right?
Uh-huh, yes.
How to overcome antibiotic resistance in clinical practice discussed already.
What
Is,
strategies can be used? Yes.
is it safe to use same antibiotic for 10 days or
Uh,
more than 10 days?
Completely depend on the condition and we
Exactly.
cannot assume that which medicine in which case, right? See, that's the only reason we have included a real world application and case based learning of antibiotic stewardship. You have n number of questions which is related on, I can see, which is related on practical scenarios that we
Yeah.
can use. हम ये कर सकते हैं या नहीं नहीं कर सकते मतलब 10 दिन तक एक एंटीबायोटिक यूज कर सकते हैं या नहीं. This is all about the confusion, so that can be solved by the real case application.
Yeah, yeah, like
That's the
all
only
cases
reason.
with the antibiotic names, amoxiclav, and metronidazole and all. I think we will take these on the case scenarios. We cannot discuss these things.
Exactly.
Yeah. Okay. How we know that it can't be given with the combination or adjuvant therapy? I mean, Tanisha. So I think Tanisha is asking how we come to know that if any antibiotic can be given with the combination or adjuvant therapy.
See, this again a part of your, daily reviewing of your medication chart. So
Yeah.
based on that, you will identify that whether it is a part of your adjuvant therapy or not. Okay, so again, you need to understand the case thoroughly from your first day of admission of patient to the taking medicines. Okay.
Yes, absolutely, absolutely. It is mandatory to give. I think there are all the questions related to those things. Someone is asking if dose or frequency was reduced on the basis of LFT, KFT elevation, then which term can we use? De-escalation, I think.
De-escalation. If
Okay.
dose or
Thank
frequency was
you very
ready, okay.
much. Thank you very
Thank
much,
you.
guys. I'm sharing the feedback form and registration form once again. If you are interested, you can register. And we will share the feedback form. I mean, sorry, we will share the link again in the groups, not feedback form at all. So if you are guys, again, if you're not filling the feedback form, you're not going to get the certificate. Please fill that. Please fill that form. And we are seeing you again on Thursday evening, 7 p.m. Thursday evening, 7 p.m. topic we are very soon announcing. And that will be again the free webinar. Okay, and you might have the luck again to register on that day. We're not sure. Okay, so we are not sure if you want to register. Please register by tomorrow. Okay, please register by tomorrow. Okay, guys, thank you very much.
Thank
So
you.
we have come to the end, and we will now end the session. Okay, we will now end the session. Thank you very much, guys. Take care. Bye bye. Good night. Good night, everyone. Thank you. Thank you, Dr. Neha. Thank you. Bye
Thank you.
bye. Bye, guys. Bye. Thank you. Thank you, everyone, for joining. Yeah, these guys are joining at the end later at the part, and then they ask for the feedback form. It's okay. At least you have joined, so you'll get it. Yeah, I'm not getting this. Here is the feedback form last time for a second only. Good night. Please fill the form without fail.